What do you think is the biggest barrier to better access to data and predictions in health?
If we could get really good quality data and protect people's privacy, in doing so, we could do an amazing amount of good with that. And then health has that golden opportunity where, in general, things that are better for you also end up costing less. The actual health system itself gets better, and therefore the citizens get better. If you've got that information across a population, then you can find those patterns and identify within that population who are the people with particular needs and vulnerabilities, and you can respond in different ways.
This is highly sensitive. You can do a million things with it. Which entity are they more likely to trust with their data?
Certainly not all governments. There are certainly some governments that have a higher level of trust with their citizens than others.
Kevin, it's great to have you here. Someone with so many years of experience in two fascinating fields, I think, for us in particular, but for our audience in general, combining data and tech with healthcare. How was your experience during COVID, the experience altogether? Does it do justice to the state of healthcare data as a field?
Yeah, thanks, Florin. It's great to be here to talk about these things. COVID was a really fascinating experience from a health data perspective, and I think most people around the world realized that it was a little bit of a point in time where suddenly people became a lot more aware of health data, what we collect about people, what we know about diseases and spreads and those sorts of things. New Zealand in particular was in quite an unusual position. We were one of the last countries to have our first case of COVID-19, and really immediately upon those first cases, I was part of a group that was pulled together to look at scenario modeling. So my day job is to run a health data science partnership, and so I have done a lot of work in modeling and health and data in that general space, and so I was sort of someone who knew my way around the health data system and the technology side. And we pulled together a group of people who weren't experts in disease spread per se, but were really familiar with data and modeling. And we immediately got to work, trying to build models to understand what the spread of the disease might be in the New Zealand context. Again, we had this fortunate position, if you like, of other countries going first and having major outbreaks and seeing the struggles that were happening elsewhere. And so we could kind of take the little bits of information that were coming out early on and feed those into our modeling efforts. And we really just then went to some scenario modeling to we were actually looking at, based on what we understand about the disease in other places, what could the spread be like in New Zealand? What are the scenarios of a worst case, best case kind of scenario? And then we were able to take that information and build a pretty basic model to start with that got more and more sophisticated over time, that we would use for sort of daily planning, that eventually sort of got used by the government and the Prime Minister's sort of daily briefing that would sometimes quote from this. And so, we would essentially look at, what's the chance of COVID having a worse outbreak? Are there cases that we haven't seen in the community, those sorts of things? And we'd use data all the way through that to try and inform the decisions. That, as listeners will probably know, New Zealand kind of took this, what seems like an extreme approach of saying, actually, given what we know, it's better to eliminate and then control it from there in the early stages than anything else. And we were pretty successful in that. So, we had a lockdown, but it was actually only a relatively short lockdown, followed by complete freedom within New Zealand. So you couldn't come in or out of New Zealand, but within New Zealand, you could do everything. Sports stadiums were full. You'd be away in bars and all those sorts of things. Everything was active because we didn't have any COVID-19 within the community. And then occasionally a case would come in, and then you'd have another modeling session again, and you'd lock down again for a period of time, and then go through that whole exercise again. But anyway, the whole experience was really fascinating, from just figuring out what you could do with data, how you could communicate that to people, how do you build trust, do you believe the outcomes, how do you look at what might happen in a country with a disease that actually you've got no historical record of the disease spread in New Zealand. So we didn't really know what would happen in a New Zealand context because every country is different, and so we had to be thinking really carefully about what assumptions you make and that sort of thing. So anyway, the whole put data and health kind of at the forefront of people's minds. It's very fascinating.
So so the reason why it looked extreme from the outside is because you didn't wait for a big match on a stadium to happen and like the hospitals to be overwhelmed with people, but you took this route where you said if this happens, then we with 90% confidence, we believe we're gonna need to shut down the country, and therefore let's do it for a short while, controlled on our own terms before.
Yeah, exactly. I mean, and again, people will have, all sorts of memories of those experiences. But essentially, everything in disease spread initially comes down to this thing called the R value, or the rate of infection. And if it's more than one, then eventually everyone gets it. And if it's less than one, then eventually it goes away. And essentially, New Zealand took advantage of the rest of the world doing the experiments for us. So we could see that R was going to be bigger than one. So as soon as we had any cases, if you didn't shut them down, it would grow. And we have a health system that's pretty good, but has a finite capacity. And you're not going to be able to get ventilators into the country and medications into the country as fast as you would need them under the scenario of a real outbreak. And so we sort of took the approach of saying, well, if we know that's what's going to happen, if we don't shut down, let's rein it back. And essentially the strategy was to do that until you had sufficient vaccination across the population, that you could then unlock the population, if you like, and sort of and gradually allow people to move in and out of the country, and that would be under the circumstance of having a population that was largely protected in terms of the vaccination rates.
So from a data perspective, I imagine you have a make or break component where you need to monitor the patients and answer the question, where are we? What's happening with the actual disease? And then an even bigger component of the environment with different variables of what's happening, how many people enter the country, maybe, how are they moving, what's the density here, the density there. And so first of all, a question like, what were the most important input data sets? And then secondly, how do you account for the seemingly random things that were responsible for the major outbreaks around the world, like the spring break in Florida, for example?
Yeah, so that's a really interesting point. So first of all, I'd point out that this isn't just one model. This is multiple models for different types of questions. And, depending on the question, you put a model together in a different way. And depending on the model, you obviously have different data that feeds into that. And so initially, the core model was all about the spread and effects of the disease. So how likely is one case to spread the disease to another person, and obviously within family environments, you'd have different kind of dynamics and work environments, schools, and those sorts of things. And so we could run scenarios that approximated the idea of shutting down schools or shutting down workplaces and reducing travel, because that would have the effect of people interacting with less other people and therefore less opportunity for the disease to spread. So we had, again, models that really were a fairly high level model of a general population of a different general size, and you could do it by population of a city or a region or a country, depending on how wide we knew the disease was actually spreading. And we had, we have good data on where people live, what kind of family, are you living in households with lots of people or a small number of people? Given where you live, where do you work, and where do you go to school? And so we could see kind of those populations of people and who they would interact with. And so we had simulation models essentially that looked at, how do people move around, and if you restrict that movement, what would that do to a rate of a disease spread within a given population. So there's quite a lot of models that were really around that kind of thing. And obviously you then have, other dynamics, like if someone's had COVID before or they're vaccinated, then their propensity to both get the disease and spread the disease changes. If you have people who are more frail or more vulnerable in different ways, then obviously their likelihood of a poor outcome goes up. And so we could see where those people were and who was most important to protect. New Zealand has a lot of rural populations that, live a long way from medical help. And so we could see that it was particularly important to have boundaries, protecting particular zones, because if the disease early on got into particular communities, it was very unlikely they would be able to get the support that they'd need in the time that was needed. We've had other models that are more about identifying who's most vulnerable. Even as recently as this year, we've been using a model that essentially looks at, if someone reports a positive COVID-19 case, what's the likelihood that they would end up being hospitalized? And the reason we used that as our sort of proxy was we wanted to understand who's vulnerable to poor outcomes and therefore potentially in need of additional care. So if you want to find people who are likely to have poor outcomes, you understand their other health conditions and things like, what those particular risk factors are in order to reach out to them when you need to reach them.
And just to make sure I understand correctly, when you say the likelihood that that person ends up hospitalized with severe disease and different outcomes, do you mean you take in consideration the particular history of that one patient?
Yeah, so what we're able to do is basically look at historically anyone in New Zealand who has had COVID-19. What do we know about them when they have COVID-19, and what are their outcomes? And we use that to then say, if you've got a new COVID case, who are the people with similar characteristics? So based on similar people, what are the likely outcomes for other people? So obviously based on things like someone's age, or perhaps whether they live in an urban area or a rural area. Sometimes ethnicity can be an indicator of other things to do with the living situation. And we pull all those factors together and into this model that then essentially gives us what we think of as a sort of a rank order of vulnerability or priority. And so obviously the people with the most likelihood of ending up with poor outcomes, they get additional services, like you might give them a phone call once a day or once a week, depending on the situation, to make sure they're getting the care that they need, and that we're making sure that they're less likely to end up with that really bad outcome.
And Kevin, what's interesting to me is that you're describing a system that if we turn all the components into abstract ideas, it sounds like it could work applied to most diseases, and please correct me if I'm wrong, it's even harder in the case of COVID-19 because you need to learn about the disease in a very short time frame. You have all these unknowns that you need to understand about really quickly, and then you have the added complexity of the interaction between people, as opposed to a diabetes type of disease.
Yeah, that's right. I think of this whole general area as the data science concept of patients like me, and you've experienced this with, if you buy things online, people like you buy this book or watch this movie or would enjoy this particular thing that I'm trying to sell you. In health, it's the same thing. Like, based on what I know about you, here's some things that happen to people like you. And when I say like you, I might mean with the same diagnosis. I might mean people who are taking the same medication, same age group, those sorts of things. And so we've got all this sort of profiling information about people. And I guess the general concept is, if you've got that information across a population, then you can find those patterns and identify within that population who are the people with particular needs and vulnerabilities, and you can respond in different ways. I think COVID's interesting in that I think you're right that it was harder in the sense of everything moved so fast and we're dealing with essentially a moving target. On the other hand, it was easier in the sense that you suddenly had global agreement to share what you could learn. And so we suddenly had way more data than we would ever have had in any situation other than this. And so, for those of us in the sort of the big data and data science world, this was an absolute blessing to have at our fingertips, was data. And then you could, start thinking about, well, I think this population is more similar to ours, and therefore, what would happen in that scenario. So you did have a sort of that, fast moving issue, but you also had just the sheer volume of information sharing that was happening. That was a true advantage, and I think there's a huge amount to learn from both of those sides of things, right? That general concept, as you've indicated, is not COVID specific. So I want to know about people like me. I want to know, for someone who gets to my stage in life and suddenly gets a diagnosis I wasn't expecting, what do the next 5 years look like? Is there something I can do? Is something that some people who, like me, had that diagnosis but made this decision, they had a different outcome than those who had the same diagnosis and made a different decision. And traditionally in health and medicine, we've always had these big random sample type trials where you control one thing at a time. Try a medication, this group gets it and that group doesn't. With data and data science, potentially you can be doing all of these experiments all of the time on everybody. I don't mean in a sort of a creepy big brother sort of monitoring of everyone, but it's sort of an empowering way where I, as an individual citizen, can say, well, I'm willing to share this information about myself with the population in the transaction. Here is that I learned from that population and it's useful to me have better outcomes for me and therefore help me to make the decisions ultimately.
So to take a step back, what kind of work do you need to do to prepare you as a mindset education for the type of activity you had to do in those 2 years?
Yeah, it's interesting
What?
because it's a really a combination of the technology side of being really clear about the data that's collected and how you get your hands on good data. What is good data versus bad data, and what do you do with missing information? So it's kind of just a general understanding of data. There's an understanding of how a system works, and in our case, a health system. How do people actually go from one stage to another? Who are the different providers? How do they share that information with each other? So it's really important to have that technology that allows you to exchange data between different providers. So that might be between primary and secondary care. It might be between healthcare and social services. But just generally understanding how data flows is really important. The other thing in terms of the COVID specific response was actually knowing the people. And so knowing the people who knew what was going on the ground and could interpret, bits and bytes of data, what they actually mean physically. How do you actually understand what those outcomes mean? What does a measure between 0 and 1 actually mean in real life? So having that sort of combination of the data, the technology, and the people that could kind of, pull everything together. And I think, deliberately having, I guess, a diverse team in the sense of skills and understanding. So not all data scientists, you need clinicians in there. You need people who are actually consumers and, have particular health needs to kind of help you understand what would that mean for a patient? How would they feel about their data being used in that way? Is that violating some privacy principles that we want to be really careful about? So you've got to bring all of those things together in order to actually run the program, because you can build the best model in the world. If no one trusts you to do it, they're not going to give you the data, and then they're not going to trust the outcomes. And so you have to actually have a whole system of, people who work together in order to actually, deliver something that actually meaningfully changes the way decisions get made.
That's extremely interesting, and what makes it's obviously very similar to how other predictive engines are built in the components, of course. I think what makes it difficult on one side and extremely fascinating on the other is the super high stakes, much higher than can you predict the number of people that will visit this store today. So I was wondering, especially given those high stakes, on both the input and the output side. On the input side, how can you test, validate, get an idea of the quality of the input data? It usually comes, I would imagine, from systems that you don't necessarily control. You trust the manufacturer of a device, you trust the hospital to report correctly some things. And then on the output, how do you prove to people that your model works reasonably well and they can trust you with your prediction of the future?
Yeah, I think all of that is, pretty complex kind of set of things that you need to get right, and you'll get them right gradually over time with as much transparency as you can. So the first thing in terms of your input is actually just being really clear what data you're going to use, how you collect it, why, what was that data collected for, and then how are you then using it? Because it's usually something different, right? You collect information, I don't know, on a hospital admission, sometimes because you want to bill the right person the right amount. And so it might capture certain information because of the reason you're capturing it, which is different from downstream. I now want to use the same data to predict, who's most likely to overstay their expected expected time in hospital. Because you collect it for one way and then use it in a different way, you've got to kind of have that understanding all the way through. So a big part of this is just documenting those things and making sure that that's visible to anyone who uses the information. You get really clear on, if you're building a model, what are the inputs, how do you define them? And I think within that, though, being pragmatic, you never have perfect information. So if you build a model, you're not going to have perfect data to build that model. Just like your doctor doesn't have perfect information about your health history. when someone asks you, have you ever had this condition before? And you can't remember. Half the time you won't remember the medications you've ever had. So if you get asked a question by a person, that's also unreliable. So the fact that data systems are a bit unreliable isn't actually that different from health practice. And so part of what we need to figure out here is how do you get better than today, not perfect, in one step. And so a lot of that is just being better and better at explaining what you're doing, making it transparent, putting in front of people, this is why I'm suggesting this course of treatment. This is what I do know. This is what I don't know. If I knew this, I'd do that. If I didn't, given that I don't know it, I'm going to make a guess, or I'm going to do, just being really open about the uncertainty, because honestly, our healthcare professionals are some of the best people in the world at dealing with uncertainty. They always, all the time, make decisions without knowing for sure what the outcome will be. And sometimes we try and build these amazing models and expect them to be somehow perfect in a world where we were never perfect before they came along. And so that's a big part of it, is that you explain the whole situation and build on that trust that's already in the health system. We trust our clinicians often because they explain that uncertainty in a way that we can understand and get us comfortable with, hey, this is a risk, and this is what, if you do this, then their outcomes could look like that. If you take a different course, then this is what will happen. But again, we're always doing that in the context of trying to make the best decision for the patient and being clear about what we do know and what we don't know. On the sort of, how do you trust the outcomes? I mean, ultimately, we need to be able to measure what we're doing in order to actually validate and continue to improve. And that's true of any model, any technology that you have. And one of the advantages with data and data science is that you can actually start to do that almost in real time. So you really are able to capture, yes, this worked, no, that didn't, or I saw that patient again and they had a better outcome or a worse outcome. And because you're starting to feed that back into the ecosystem of data around it, you're getting better and better in the knowledge that you've got. So I think it's really about having a process that sort of honors the fact that we don't know everything along the way, but we can actually document why we make each decision, and you've got to be willing to learn. So, models will make errors is one word for it. They will have to learn because they'll gain more information. But in reality, our physicians that we see in a clinical setting, they take everything they've learned from their own experience up to a point in time. A technology and a data model can actually take everything they've learned from everyone's experience within a system over time. And so they can have a whole lot more that they've learned from, and that kind of can drive, building confidence over time. And I think, we have to get better at explaining why we do things and what the outcomes are with that information. And people will, like anything, if the outcomes are good, people will gradually adopt them.
Translating from nerd to English.
That's right. Yeah, which our doctors do really well, to be honest. They are incredibly intelligent people who, doctors, nurses, physicians of any type, they're incredibly educated, and they know stuff that they'll never be able to explain to the rest of us who aren't medically trained. But they, the reason we trust them is they'll explain it in a way that helps it to make sense for us.
100%. And how relevant do you think the experience you've shared with us of how the entire system was built, how relevant or how good of a testament is that to where the healthcare tech plus data is right now? Is it, from the outside, it seems like it's a bit lagging behind, it's playing catch up, and surprisingly so, because it's an industry with a lot of money flowing through it, with super high, if not the highest level of importance from the consumer's point of view. And surprisingly so, it does look like it's a bit lagging behind.
Yeah, I think there's a few things going on in there. It absolutely is lagging behind. One of the reasons it lags behind is the complexity. So health is not easily simplified down to a single output. So often, if you're trying to build a model to, improve your sales or retain customers at a certain rate, you've got one metric that you're laser focused on improving, and everything else is subservient to it. In health, you're trying to manage quality of life, the cost of delivering that, the equity of care across a population, the burnout rate of your clinical staff. Like, there's so many things that are even at a high level are are almost competing with each other as overall goals. And then you get to the next level of actually health means a lot of things to a lot of different things to a lot of people, right? It's individual conditions that people are dealing with day to day, some of which are what we think of as acute, so they happen at a small period of time, and some are long-term conditions. And dealing with those two things are very, very different. But our healthcare system and our providers are tasked with doing things for the short and the long term, doing things now that might prevent a bad outcome later. And there's all sorts of interesting kind of dynamics that kind of evolve from that. So I think one of the key challenges in health has been the incentives. So who's most interested in my health outcomes 10 years from now? The real answer is me, but the systematic answer is sort of about the health provider or the insurance company or the government or whoever it is that's paying for my healthcare. They have an interest in those things, but we don't sort of marry all those different interests up and actually make it really easy for people to make a good decision now for what happens later. So I guess, it's a long answer to that kind of challenge, but the reality is in health, it is complex. That the multiple objectives gets complemented with the fact that there's also multiple quite different data types you're talking about. So if you ask, what data do we need to know about you to know about your diabetes? Well, that might be some basic information about your weight and your age and your blood glucose levels, some metrics like that. But maybe I'm wearing a device that helps monitor my movement. And so I've suddenly got a movement device that's actually, understanding, how is my ability to actually exercise going over time. I might have, different ways of measuring all sorts of outcomes about myself. But there's also, my own mental health will have an impact. So, am I feeling good about today? My diet is going to have an impact. So just think of all the different data types that we've kind of thrown into the mix of that sort of description of what influences my diabetes outcomes. And that's a really complex set of things to bring together into one system. And again, you bring it in for a clinician to help give advice, or you bring it to a patient who's actually trying to make decisions themselves, translating that into language that makes sense to everyone, and ultimately gives you a clear decision of what I should do that's in my own interest and cost effective. There are so many dynamics in there, and I think that's part of the challenge with health is it's not just one thing. It's that so many things with so many inputs to get there. And I don't know if that sort of gets into your earlier question, which is, how does that describe the system we have today? And I think that's the reality, right? We have really, I guess, basic computer systems, if you like, that often manage health records. So things like my health history, it's obviously a big part of understanding my future. That's captured in one type of data set. It's very different from the data that I collect on my phone about my own personal behavior and those sorts of things. And merging those things together is actually quite challenging. And am I willing to put my personal information into some repository for other people to then analyze? Maybe, maybe not. Depends if I trust them. It depends what they think they're going to do with that information. And so there's so many different things that kind of come into there that mean we haven't settled on one way of doing this work in health. And so you have pockets of really cool things happening in individual technologies, but you haven't got sort of the whole picture pulled together in a really nice, comprehensive way yet.
But before understanding if consumers are willing to, is it technically easy to combine these sources of data from the government, sources of data from the actual clinic, sources of data from your phone and your watch, and actual medical devices, some in the hospital, some at your home, and so on? Is it easy to combine them?
Easy is probably a stronger word than I'd use, but it's possible now, and the technology is getting better and better. I mean, certainly in the world that I'm in, so I'm at a company called Orion Health that does health data software, and we've built a whole lot of data capturing and storage and analysis software through these research kind of projects that we've been involved in, and we've learned that you can't get really rigid and only deal with data in a certain type at a certain frequency, because the difference between a genome, which is a huge data file, but it's kind of static, and the streaming data from my watch is so fundamentally different, and yet both of those are really interesting things that capture something about my health condition and my potential outcomes. And so putting those things together and then meaningfully figuring out how to actually combine that data and pull that together for a picture about a person, it takes a level of sophistication that we're only really just getting to with our sort of data science and AI type of approaches.
So there aren't any major artificial barriers put in, like nonsense of I won't open my APIs from this type of device or anything like that.
No, I mean, you certainly see behaviors like that within certain systems, and often you do have a sort of a protective kind of setup where people refuse to share data with each other about their patients, often in the guise of protecting their patient's privacy. So often you're not allowed to share data about your patient unless that patient actually says you're allowed to. And so you've got challenges of actually getting permission to do that. So it's more actually getting a free flow that's kind of built upon the trust of the patient than it is a technical problem of being able to share. But those things are solvable. We just need to figure out the best organizations and entities to kind of be that aggregator of information, again, to help make better decisions overall.
And do you think patients are more likely to trust, which entity are they more likely to trust with their data? Because this is highly sensitive. You can do a million things with it, especially if we get to the DNA and the genomics part of it.
I mean, it's a really tough question.
Government?
Well, certainly not all governments. I mean, there are certainly some governments that have a higher level of trust with their citizens than others, and that does make a big difference. Like any other entity, governments have to earn the trust of the people whose data that they're requesting. The interests should be clear of whoever's actually looking after the data, whether it's a research institution, a government, a health provider. We tend to see, across the world where there's a single payer, like the government that funds the majority of healthcare, they tend to have the ability to pull together data because the citizens are sort of understanding that it's in the government's interest to plan for the future and to do the analysis. And there's less opportunity, for example, for someone to get disadvantaged because their health data reveals something about themselves that they don't want to be revealed. That's a much harder thing to do in a world where you're paying for your own healthcare, or even where there's insurance companies involved, because telling my genome to a potential insurer just invites them to go through and say, well, what are the risks that I then want to write out of their policy, because I don't want to take on risk that I know is there. And so in some ways, those finding those entities that kind of have it's in their interest for the overall population health to improve, and it's not in their interest to disadvantage any individual. And again, in some countries, that's research institutions, and in some places, those are government. Some places there are sort of large insurance type organizations that take on the whole population, and it's in their interest for the population health to improve, and that can work as well. But I think we just need to sort of segment that question into the different jurisdictions that we're talking about, because it's not like, I can say on an international podcast, you should trust the government or you should never trust the government, and half the listeners will agree with one of those statements. So it's it's going to change in each place.
And the responsibility, actually, the insurance point you made, which isn't something, I'll admit, that I thought before about in healthcare. It's very similar to other debates we've had in the previous decades, like basically the fundamental effect where the person's prerequisites, history, education, parents, level of income of the parents, and so on, kind of end up predicting their outcome because of the limiting factors of because your parents weren't educated enough, you won't be able to access good enough credits, for example, and then therefore not be able to access good enough universities and so on. And this has been a debate, rightfully so, for the past decades. In this specific scenario, and with healthcare, it has much bigger implications. Um, in the case of you as the platform who manages the data, overlooks the data transfers and so on, are you the one responsible to sort of say you're not allowed to do this with this patient's data?
So when we provide a platform, we provide the ability for whoever's running that platform to make those decisions. So we don't, we're a technology provider, that facilitates good decisions around their data. Usually we will be providing that on behalf of some sort of a health provider entity, and they will have their own rules in place. And so those rules can be down to things like consent. Do people give consent for their data to be used in certain ways or to be viewed by certain people?
Yeah.
And so we need to guarantee that our technology will do what will enable those rules to be followed and those rules to be monitored to make sure that that's actually being we're following through on the preferences. Obviously, in some jurisdictions, certain data has to be captured because it's required by law to keep statistics on certain things, or to not. You can't just delete people's health records because it might become important in the future. So even if they prefer to be deleted, that doesn't mean you actually can or should exactly delete the data. So there's a whole lot of sort of technical bits in there about what you can and can't do. We don't tend to play the role of setting those rules, but enabling the rules to come about. We do get involved in helping people with data governance and the governance of things like introducing AI and advising people on, how do you make those assessments of when it's appropriate to use new technologies, and how do you make sure that you're honouring the intentions of people whose data has been captured. And so we'll provide advice in that sort of space, and I'm involved in a number of those sorts of initiatives. But we, as a technology platform provider, we're really there to facilitate whatever a given healthcare provider actually wants to be able to do with that data.
And I think you as the third party in the middle have a very privileged place to have visibility over the entire ecosystem. How has it evolved in the past 7 years?
Yeah, that's a great question. So, we have visibility over the ecosystem. I should be clear, we don't instantly have visibility over the data. So we follow our own rules in terms of, we can't just look at data just because it's on our platform. Again, that's part of the whole contract that we have is, you look after data well for those people. Over the last 7 years, we have seen massive advances in things like artificial intelligence. So people are wanting to add sophisticated capabilities to help them manage the fact that data is growing in terms of the variety of data and the volume of data that's coming through, and wanting to apply different sort of machine learning capabilities on top. And so that's one of the big changes that we've seen in that time. There has been somewhat of a consolidation toward bigger platforms with more data about population. And so we used to think of health data reasonably narrowly being about diagnoses or medications or laboratory results and sort of basic things. And now we know more and more that, your health outcomes are driven by your social circumstances just as much, or you've got things like your genomic information on your data. And so the other big change is just those different types of data that are now considered to be part of your health record, and therefore of interest to a health system to actually be able to capture, store, understand, and then translate into better decisions. And so it's a much more complex sort of broad set of things that you want to do with health data, coupled with the AI side of things, where there is actually technology that can help us handle that and, get through the data processing that would have been impossible in previous technologies.
Yeah, good points. Of course, and of course, you cannot treat the data in a way in which it wasn't intended to.
Yeah.
It's part of your responsibility as a platform.
Yeah.
Do you think, are we headed in the right direction? Are we gonna see what can be called as a disruption or a major change in the ecosystem? Is it gonna become much more exciting? Are we as consumers gonna have access to a lot better predictions in the near future?
I think we will. And I think one of the reasons that ought to happen is because we're focusing much more on consumer-facing technologies. And so partly in the past, we've always provided for the clinician first. And so it's always been, the government or the health system or, the nurses and doctors that need technology. They're the ones funded to deliver healthcare. I think as we sort of turn things around and try to present health information directly to consumers and enable people to manage their own health, as citizens and consumers, we will demand much better technology to actually allow us to do that. And I think that is one of the things that will drive a real change in capability. And you see that even through people trying things like ChatGPT across health records and those sorts of things. We're getting the ability to try and explain things to regular citizens that would previously have been sort of a privileged piece of information for a clinical staff or a health system. And so I think as soon as technology starts, taking the power away from the center and putting it back into the hands of the person who ultimately cares the most about health outcomes, which is the patient or consumer themselves, then I think we'll definitely see that disruption coming that we've talked about for a long time, but not really seen that much of. So I think there's definitely disruption coming. I mean, you won't take away from the fact that you still need a robust, trustworthy underlying health system to manage, overall population dynamics. But I think around the sort of area of people managing their own health and their own wellness, those tools that will come through technology will fundamentally change our ability and almost give people that ownership back of actually I'm not helpless and just always relying on an expert to be able to do something. I can get access to every medical journal that's ever been published. I can go and do a search now and ask ChatGPT to translate that into language that I understand. So there's no way, you no longer need to go to some the only world's expert in something to understand it. You've got technology that enables you. And if you think of that power, and then the next step is saying, well, what can I do about this? And again, learning from the masses. Every person has much more access to the knowledge that's out there. And I think that's where the technology is really going to change things, is powering people to actually, own that themselves and make those decisions.
Yeah, I'm really looking forward to that. So, especially as a data aficionado, I find it a bit uncomfortable that I need my organs to give me feedback on my behavior. If it doesn't hurt, I'll just assume it's okay. It's a bit weird.
Yeah.
When just as a last question, what do you think is the biggest barrier to a better access to data and predictions in health?
So I think certainly one of the biggest barriers has always been the sort of siloed nature of our health systems, that because hospitals tend to be separate from general practice, which tends to be separate from our dental care, which tends to be separate from our own personal kind of information. The fact that those, that data, there's still, sort of, if you like, mainframe style systems that look after core data. And by sort of capturing it in a way that's always just been serving the system and to some degree the clinician, it hasn't been formed in a way that's primarily for the consumer. And so that barrier is really the legacy of our information systems that are out there. And I think the more we can think of ways to actually take data from those systems and put it in other systems that are much more flexible, much more accessible, that also have the protections and can do things like de-identify the data and protect people's privacy, the more we'll then unlock all of that value and that sort of that opportunity that sits there in the data. I think we know this, everyone who works in data, that if we could get really good quality data and protect people's privacy, in doing so, we can do an amazing amount of good with that, and especially in health. And health has that that golden opportunity where, in general, things that are better for you also end up costing less in the end. And so, the economics work really well. So it makes sense to do the right thing that's going to give you the best outcome. There's not this weird dichotomy of, should I pay more and have better outcomes. It's actually almost the other way around. That if you get the incentives right, the actual health system itself gets better, and therefore the citizens get better. And so, we got to get those incentives right, and we've got to unlock the data that's in those siloed systems.
Sounds amazing. Thank you so much, Kevin. It was a great pleasure. Thank you for the time. It's a fascinating topic, and it was an honor to learn about it from somebody with as much experience as you have.
Thanks very much.
How can people get in touch with you? How can they learn about your work?
Yeah, so I'm at Orion Health. So if you can look up Orion Health as a software company, and I look after a number of the products there. I'm also on LinkedIn, so feel free to reach out to me there.
Thank you so much, Kevin. It was a pleasure.
Thanks.